next speaker is Dr. Brooke Spencer. She's going to talk to us. So many of you have POTS, right? Can we have a POTS hand? Marla, by the way, if people don't know, she's my assistant, and she wants to return her POTS she does not like. Yes, 10 out of 10 do not recommend. Okay, so, but I think when you talk about POTS, what you don't understand is that it's part of a spectrum of disorders, and the way not only the connective tissue works, but also the connective tissue in the veins and arteries. So today we're going to talk about pelvic venous disorders. I even managed to spell that one right, even though it was on the website wrong for months. And we're going to try to do this as best we can. And here is Dr. Brooke Spencer. All right. Another one who's doing like the fly in, fly out, which at the end of, as someone who runs a conference, I'm very impressed that you guys do this for us because it's a gift. It really is. All right, here we go.
Well, it's on? Yeah, okay. Yeah, thank you so much, Sally. I'm really touched and honored to be invited to come here because I am not an endometriosis specialist. But there's a huge amount of overlap. And so, but I never imagined, I live in a world where the work I do is gaslighted by my own colleagues. And so it's really inspiring to get to hear, I get to hear every day the patients' stories of yours of being gaslighted and the difficulty it is to even express what's going on without being told you're crazy and all the rest of this. All the patients I see are the same patients that are seen in endo clinics as well. But it was really cool to have the experience today of listening to Kira and finding out from those guys and Casey about feeling like actually really inspired about it instead of feeling discouraged about it or having like a negative response. So that's the first time. I'm an interventional radiologist. Our subspecialty when I started was 2% women and is now up to 12 or 14% women. So I also am never in a room that has more women than men in it at a conference. So that's kind of exciting. Although, I mean, I love my male colleagues. They're wonderful, but I'm just saying it's a different experience for me. So thank you for having me. How many people have heard of pelvic venous disease? Okay. So, and I know we have a really big mix of people who are in the room. So if we can change, I can stop. If it's too over people's heads or something, they want to talk about something different, we can shift because this is partially for patients and partially for doctors. And I know we have both, but let's just jump into it. I think what I'd like to do is spend a short amount of time. I'll make it as short as I can, maybe 20 minutes or 30 minutes if that's too much. Interject, ask a question as we go. But I kind of need to lay the groundwork for like what this is, because I think people don't even know what it is. And then I put together a little jeopardy game. So you guys are left side of the room and you guys are right side of the room. There's two teams. So nobody has to feel like they're put on the spot. And I'm only in and out because I have to go present our data at the Society of Interventional Radiology meeting tomorrow. So this is the pelvic venous anatomy. And I think there's a couple of things that are important. I don't know if is there a pointer on this thing? No? Okay. So, you know, the relationship of the arteries and veins in the abdomen and pelvis is what causes iliac vein compression or May-Thurner. How many people have heard of May-Thurner? Okay, so as doctors, we're trying to get away from that term. They call them NIVL lesions, NIVL, non-thrombotic iliac vein lesions, because they don't have to only occur where the right artery crosses the left vein in front of the spine. But that's the classic. Dr. May and Dr. Turner from Germany reported this in the 50s in cadaver studies, and about 28% of the population has an iliac vein compression. So this is a very common problem that's touted as being very rare, which it's not. It's just that not everyone who has it is symptomatic. So we're still learning a lot about all of this and who's symptomatic and when they're symptomatic and why. But iliac vein compression occurs where the right common iliac artery crosses the left common iliac vein as it comes up out of the pelvis, goes across the spine to get to the inferior vena cava that then takes the blood flow back to the heart. So compression can occur on the right side or the left side. whoops, sorry. You know, if you look at this image, it doesn't have to occur up where the bifurcation is at the top, the split in the Y. It can occur in the mid pelvis on either side as well, which is why we call them nivel lesions, and then post-thrombotic or clot-related lesions can do the same thing. When recently, because of all the confusion in this space about venous disease, the American Venous Lymphatic Society got together and had 10 doctors create this. It's called the SVP classification. It's very complicated, looking at symptoms and varicose veins and then pathophysiology. But I think it's helpful to think of it this way. They created like this concept of 3 different zones, and the legs are zone 4. Zone 1 is up at the level of the kidneys, where you can get a compression of the renal vein. Who's heard of nutcracker? Okay, so we'll go over what nutcracker syndrome is and how that's related to pelvic vein disease. And as you can see in this picture, the left ovarian vein, which is the linear one on the left side there, drains into the left renal vein because it's got to come across the body to get to the right. So a lot of the symptoms in people are often more common on the left, but you can get symptoms on both sides, and some people can even have right-sided symptoms only. The right one goes straight back into the inferior vena cava and back up to the heart, which is why it's less often involved, because almost everyone has some degree of narrowing of the kidney vein where it has to go over the aorta and under the superior mesenteric artery. And then patients can have varicose veins around the uterus and ovaries, which is zone 2 in that mid-pelvic region where iliac vein compression and varicose veins occur. But then there's also zone 3, which I find even vascular specialists, even ones who specialize in this, ignore. And really, that's the place where we're even the worst, which is in the extrapelvic region, or the pelvic floor, labia, vagina, perianal, perirectal. So a lot of patients that go to a vascular specialist that does treat iliac vein compression or ovary vein reflux or blood flowing the wrong way into varicose veins frequently treat those and then say you don't still have pelvic venous disease when people have vulvodynia or pain in the vulva, the labia, painful intercourse. And frequently those patients do still have pelvic venous disease. So we're really far off from like getting this understood and diagnosed in patients. When I see a patient, or when we see someone in our clinic, this is what we inquire about. So we ask every patient, the first thing is surgery and endometriosis, right? Because a lot of patients have pelvic pain on the basis of endometriosis. But if you look at endometriosis surgical literature, and we could probably ask some of the endometriosis surgeons that could speak to the reality of this, but anywhere from 35 to 55% of patients, when they do a laparoscopic surgery looking for endometriosis, don't have it, right? So those patients have something else. And there are lots of people who have both. So this is a very high volume of patients that have pelvic venous disease as well. So we look for, did they have a response to hormones? That goes along with endometriosis. Venous disease can get better too. It is affected by the hormones. The veins are affected by the hormones, but the cyclical nature of things would suggest more endometriosis and venous disease. Most of our patients have had endoscopies, many of them cystoscopies. That's looking at the bowel with cameras and looking at the bladder with cameras. Many of our patients have had pelvic floor PT. I know they're PTs here. Thank God. They're my favorite people who help these patients the most before and after surgery. A lot of these patients, who's heard of the midline compression syndromes or this concept? So some, but not a ton. So a lot of the patients have kind of a mixed disease process where they can get a problem with their celiac artery. That's what MALS is. It's called median arcuate ligament syndrome. It's a big mouthful that just means where the diaphragm comes in to insert. If it inserts really low on the first artery that comes off the aorta in the abdomen and goes to the liver, spleen, and stomach, there are nerves around there that can get pinched by that low insertion of the diaphragm and give people upper abdominal pain, food fear, nausea, difficulty eating. So that's called MALS. And then a lot of our patients also have SMAS. That's called superior mesenteric artery syndrome. It's a mouthful, really just where the bowel comes around after the first part of the duodenum or small intestine before the second part. It also has to sneak between the aorta and SMA, which I'll show you in a minute, like the kidney vein does. And if it gets super pinched, people get vomiting, all of their food backs up, they can't eat, they get upper abdominal pain, food fear, nausea, vomiting. Some of my patients have feeding tubes in and they weigh 90 pounds and they're starving to death. And frequently MALS or nutcracker or SMAS are to blame for that. Nutcracker can also cause those symptoms by rerouting blood flow around the spine and the nerves in the upper abdomen that innervate the upper abdominal organs. And And those can all be, well, Mal's and Nutcracker, there is a nerve block you can do. It's a CAT scan guided procedure where they put a little needle in, numb that area. And if all your symptoms are gone, it would suggest that's what the problem is versus another. So there's a whole way to think about what patient's symptoms are and then work it up and figure out what's most likely to be the problem so that we get to the fewest number of procedures possible to help a patient, right? Like, as you guys said, it's great, but having surgery after surgery after surgery is not fun for anyone. And then postural tachycardia syndrome, we'll talk about that a little bit. Mast cell activation. Who's heard of mast cell activation? Well, even more people, right? So the mast cells are inflammatory cells that respond to histamine issues in our immune system. And mast cell activation just makes everything worse, right? So classically, that's rashes and GI issues. The mast cells tend to affect the skin and the intestines the most. But if we can get good mast cell stabilization, or if we can decrease the body's stress by fixing these vascular problems and the empty right heart issue, we feel like people's mast cells stabilize significantly and we see a lot of improvement. So there is an interconnection there as well. And then I think it's beyond today talking about metal allergies and things that's a whole can of worms we could talk about if we need to. But then we look at their symptoms, which is very similar to the symptoms. I'll just let you guys read it there, that we talk about when we look at endometriosis, right? So urinary tract infection symptoms without an infection or interstitial cystitis is frequently contributed to by venous disease. Irritable bowel syndrome frequently contributed to by venous disease. Back pain was present in 96% of the patients in one of our study. We have a 23-year-old girl that one of the med students wrote up a case report on. 10 spine injection surgeries, radiofrequency ablations of nerves, a fusion of her back, no improvement of her back pain, stented the iliac vein, all of her pain is gone. So back pain and bilateral lower extremity pain in young patients is frequently on the basis of iliac vein compression and often, or not often, but rarely diagnosed. Orthostatic intolerance, that's the whole POTS thing. You stand up, you get dizzy, you get lightheaded, your heart races, you can't exercise, migraine headaches, and then lower extremity groin pain and swelling. So after we do that, we do all of these quality of life surveys on every patient who comes to our office. We use the International Pelvic Pain Society survey. It's not a validated survey, but it was designed to help practitioners follow patients' symptoms across a broad number of issues associated with pelvic pain. The PUF is a validated quality of life survey for interstitial cystitis that looks at the likelihood of improvement in urinary urgency and frequency before and after interventions. The OHQ survey is specifically designed to look at orthostatic hypotension, or postural tachycardia, which is where you stand up, you feel bad, or pass out. Right. The Rome IBS scores are related to irritable bowel. We use a visual analog pain score, the score of 0 to 10. And then we also use the patient's global impression of change, which doesn't necessarily mean that whatever procedure you did or didn't do is what's causing your quality of life to be better or worse, but it just says, are you better or worse at each visit overall? So this is the anatomy for Nutcracker, where the renal vein on the left side, which is blue in this picture, has to come from that kidney. It goes between the aorta and the superior mesenteric artery. So it comes off like an elephant trunk. And if that space is wide open, then your renal vein and your duodenum, which is the intestine for SMAS, are wide open. If that space is very narrow, then you may be pinching the renal vein and or the duodenum. And so that's why Nutcracker and SMAS tend to often exist in the same people. This is where the autonomic ganglia live throughout the retroperitoneum, which is that space around the aorta and the inferior vena cava in the back of behind our abdomen and abdominal contents in the back of your body. And this is where the innervation to the bowel and abdominal organs exists. It's also where we reroute blood flow around these venous obstructions. So we don't know what the pathophysiology is behind the pain related to venous disease for sure yet, but I'm going to give you our theories, and we're doing a lot of research to try to work this out and prove this. The left-hand picture here is a picture of a venogram, which is where we put a fancy IV in the patient's saphenous vein, which is a superficial vein in the thigh, and inject X-ray dye. If we see that X-ray dye come up to an area where that artery is crossing, which you would think it'd be just a line, right? But it's not. It's a big round vein. So you get a funnel shape narrowing like a pancake. It looks really wide like that over a long segment. And this person is rerouting their blood flow up around their spine, through their spinal canal, and across their pelvis. So the innervation of the pelvic floor, the bowel, the bladder, the uterus, and the vagina comes from L4, 5, S1, S2, which is the same as a sciatic nerve. And that's all in the bottom of the spine. And I believe that these dilated veins that are pressing on the nerve roots for all of that contribute to pelvic pain. I've been challenged to prove that, which means we're going to have to do some cadaver studies. Everything yellow in the middle picture is those nerve roots that are coming out. It's called the hypogastric nerve plexus that's coming out of the spine and running down through the pelvic floor. So this is that same patient early on in the injection, later in the injection, that shows that the veins are filling every single level where those nerve roots are coming out of the spine. All those horizontal little things are dilated veins where the nerve roots trying to come out of the spine. And then the picture all the way to your right is after a stent is placed. And so this is the same patient. We're not getting rid of any of these. And there is no such thing as a collateral vein. So body doesn't grow new veins. There's collateral venous drainage pathways. And I make the distinction because there are some people going in and trying to embolize these veins or get rid of these veins without stenting the patient because they're afraid of stenting young patients. It's very dangerous. It remarkably increases your risk for clotting your whole leg, getting neuropathy, having horrible pain. And so really what you want to do is stent the vein and take the pressure off all these veins, let them decompress. You can go back and embolize the abnormal pooling veins afterwards, but you can't do that before you fix the compression. So unfortunately, this space is still pretty poorly understood. This is what it looks like when we put a stent in. So we have, I actually draw on the screen. I know it sounds corny, but if anybody here has been in any of the Facebook groups or things where people have chronic, horrible, unrelenting back pain, it's frequently from oversized or incorrectly placed stents. So you can see that when the vein is very wide in the middle picture, the stent looks like it's going to be way too small, right? But on the final picture, it looks like it fits the vein. Well, when you take a flat vein and you look at it from the front, it looks really wide. If you look at it from the side, it's like a pancake. If you turn that round, it looks much smaller from the front. So we have to use intravascular ultrasound to evaluate that. And this is an intravascular ultrasound where the little catheter, the white ring and the dot, are inside the main inferior vena cava. And as we pull that down, that's where the artery is crossing over the vein. And you see how narrow and compressed the vein gets, but it's over a pretty long segment that the vein is distorted. It doesn't come back to normal till the mid pelvis in this patient right here. And that's what the vein is supposed to look like. So when we do an intravascular ultrasound, we can measure the normal vein, measure the curve of the pelvis, which is naturally smaller, and then the external iliac vein at the bottom. And then that allows us to go back and put a stent in that's the right size for that patient. Now, we used to put short little stents in, but they could move or migrate, because if you oversize them too much, you get horrible back pain. If you undersize it, it can migrate and end up in the heart. So this technique was switched a few years ago, but not by everyone. So this is why it's really challenging for patients to find practitioners that are comfortable doing this, know how to place these and size these correctly to get good long-term outcomes. Okay, so these are some pictures of nutcracker patients. The one on the left is kind of a mild compression. You see that white line is kind of the filling, the squish, like somebody just went up and put their finger on there and pushed against the vein, but we still have blood flow out of that kidney vein. That's often asymptomatic. In the middle, we have one where there's split blood flow through the kidney, but it also goes around the spine, in the spinal canal, around the nerve root and the spinal cord. And then on the far side, we have one where all the blood flow goes in and around the spinal cord. So you can imagine why not only is there decreased blood flow to the heart that can contribute to POTS, but there's also, a reason for you to have chest pain and upper abdominal pain, food fear, nausea, vomiting, and all those things, because that's the innervation of the upper abdomen and bowel. And then this is a picture of the more classic nutcracker where the blood flow is going backwards in the ovary vein instead of forwards. Now, if there isn't a bad nutcracker and the blood flow is going backwards, we can go down that vein, all the way through the uterus to the other side if we want to, and then we can coil that off and close that vein and use some medicine to kind of chemically close the varicose veins associated with that. And then this patient also had vaginal and vulvar pain. And we have to go down and look in that zone 3 in that pelvic floor and get rid of all the varices if we actually want to fix the patient. This is a patient who already had their ovary vein coiled. You can see the coils there from before, but had severe interstitial cystitis and urinary urgency and frequency. This thing is sensitive. And these are varicose veins around the bladder looks like a heart. So I like this one, but it wasn't loving this patient. But these are varicose veins all the way around the bladder. And the reason this doesn't get diagnosed by urology is, first of all, we've done a terrible job of publishing data. They don't know anything about it. But second of all, you can imagine if you put a catheter, if you put a scope in the bladder, in order to see it, they fill it up with fluid, distend the bladder, it compresses all the veins and you can't see it. It's similar to the fact that when they do laparoscopic surgeries and things to try to look at the ovaries and the uterus and endometriosis, you often fill the abdomen with carbon dioxide so you can see what they're doing and create a space, and it compresses all the veins. And so this doesn't always show up on surgery. So if it does show up on surgery, you have it really bad. And then the last thing we do is that my sonographer is amazing and she listens to women and her patients. So what she started doing is someone would say, I have pain here, and she would go look. And so I haven't found any other place in the country that does it, but I've had her be able to explain it to other people to try it and do it successfully at times. But we actually do a perineal ultrasound. So transvaginal ultrasound is going to miss this. You put the probe in the vagina all the way up to the level of the cervix. This is zone 3. This is all the stuff in the pelvic floor that you're not going to see. And these veins that are dilated in the pelvic floor, like varicose veins you see on your leg, are deep enough you can't see them on the surface. And so you have to do an ultrasound from the outside to find them. So we just published, and we're about to publish an article on that technique and how to look for that. And then this is what we do when we find them. And unfortunately, this is very technically challenging. So I'm hoping we can train a lot of people to do. I've trained some people, they've had trouble with it, but we use ultrasound and use a small needle. People are asleep, by the way, when we do this, and put a small needle directly into those varicose veins and then do a venogram, and we can light up the entire vagina, labia, and vulva with varices. And my friend Grace Knutson at Mayo Clinic in Scottsdale asked me to review a paper she's about to publish on vulvodynia that showed a significant improvement from treating these. And I've done about 200 patients now, and we'll be publishing that as well. But this is a frequent problem that just doesn't really get addressed very often in many practices. This was a young woman who had stents placed for a blood clot and ended up reclotting them. So those stents became kind of like a covered stent, which meant, where does the venous drainage from the pelvis go? She had horrible, horrible tailbone, perirectal, and coccyx type pain at the bottom of her tailbone. And I was able to get in the veins outside the rectal wall, just next to the rectum. And then we inject foam sclerotherapy, just like we inject sclerotherapy into varicose veins in the legs, and make that go away for her. So, so I know this is a super interactive meeting, and I really loved that part of it the most. So I don't want to just stand up here and lecture at you guys. I felt like that part was necessary for you to understand the difference between obstructive disease or compressions like May-Thurner and varicose vein disease and where it's located and things. So, I mean, I have lots of literature and data I can show you on what we know and what we don't know. I made a jeopardy game so that we can play a game about dispelling myths and ask some questions. But I need feedback from you guys about, like, would you rather just ask questions and have an interactive discussion for where we are with this? Or do you want more of me prattling on to show you the data? I don't know. Play the game and then we can come back. Okay, game. Okay. So before we play the game, I do want to show you this slide. This is from Alexis Cutchins, a brilliant cardiologist. She's at Emory right now. And she and I have been working together on the POTS stuff. And there's this, you know, a lot of people with these multiple diagnoses are diagnosed with all these things or many of these things. And the one thing that's frequently missing from their diagnosis is venous disease. POTS contributes to some of them, and some of them contribute to POTS. It's all interrelated. So there's the mast cell activation, the GI dysmotility, the small fiber neuropathy, cognitive function, brain fog, and fatigue, right? And mixed connective tissue disorders are frequently involved in this because when there's a collagen defect making you hypermobile, type 3 collagen is the largest thing that makes up a vein wall. So you can have pressure that's to a less degree if you're hypermobile and have more venous pooling. So before we do the game, I'm going to skip all this stuff, which we can go back to at any point if anybody wants to. And I've given a bunch of talks online, so it's probably somewhere. And I just want to show you real quick because I'm going to present it on Monday, but you guys get to be first. So this is a study we submitted for publication yesterday of 271 female patients with postural tachycardia and pelvic pain. And what we found is that, the average age is 36 years old, young patients. And if you look at a Mayo Clinic quality of life survey, the quality of life of patients with POTS is the same as patients with congestive heart failure and COPD. But yet the only therapies we really have for POTS outside of slowing down the heart and then giving medicine to increase the blood pressure is a high salt diet, which is not great for you and not long-term sustainable, or putting in an IV and giving you large volumes of fluid every day, right? So these are not super sustainable. And most patients, they never get cured of POTS, right? So the average amount of compression in our patients was 78%, which is pretty high. Like anything over 50%, you can consider stenting. But just to show you, if people are like, oh, they're just putting stents in whoever, I mean, most patients had a fairly severe iliac vein compression. And then we use these POTS quality of life surveys, but this is the one that's most important to me. We're not perfect, right? So we can't guarantee we fix everything in patients with complex disease any more than endosurgeons can, right? We do the best job we can in each patient, but we saw a statistically significant improvement in these quality of life surveys in the POTS patients after iliac vein stenting at 3 months that lasted to a year. And what was exciting to me is that 71% of them said they had a meaningful change, which is, not as high as we'd like it to be, but many of them still had varicose veins in the legs or other things that could be addressed, or nutcracker, which also decreases blood return to the heart. But 44% of them no longer met criteria for POTS. So for a disease that's incurable and that is lifelong and that you suffer from most of the time, that was at least exciting as a beginning. The pelvic pain results, same thing. Decrease in pelvic pain at 3 months, lasting out or continued improvement out to a year for the International Pelvic Pain Society. The Pelvic Congestion Society, same thing for the interstitial cystitis survey. And one of my med students just pulled out 171 patients for these PUF scores that demonstrated interstitial cystitis level findings before and showed a statistically significant improvement at 3 months that lasted to a year that we're going to publish soon as well. The ancillary symptom score, Steve Smith took a Facebook group of women complaining of chronic pelvic pain. I shouldn't say complaining, reporting chronic pelvic pain, and asked them what other symptoms they had. So this includes stuff like excessive sweating, migraine headaches, temporomandibular joint problems, all sorts of seemingly unrelated symptoms. And we saw an improvement in that lasted. And the patient's global impression of change scores at a year, so that 80% of people were better, which is a fairly high number in people suffering from bad chronic disease. So the last thing I'll leave you with before we do the fun stuff, right? This is the incidence or the percentage of patients that had all of these different symptoms. And 35% of our patients were hypermobile, but I think it's grossly underdiagnosed. Go back. What? Okay. So and then one other thing I'll say is that if you go to a general vascular surgeon, cardiologist, or interventional radiologist that does iliac vein stenting, they'll often tell you that if you have an iliac vein compression, unless you have a blood clot in your left leg swelling, or varicose veins, you don't have symptoms from May-Thurner. So we just did a multi-center prospective trial with Mayo Clinic, Thomas Jefferson, a few other private practices that was presented at the European Society of Interventional Radiology and won an award, which I'm really excited about, raising some awareness, that showed statistically significant improvement after treating venous disease. 80% of them were stented, 20% of them were embolized for the varicose veins at 3 months that lasted to a year. So we're starting to build a body of evidence to suggest that from at least patient-reported outcomes, that this is consistent across multiple practices across the country. But 55% of our patients had bilateral pain. Only 13% had unilateral left leg pain. So if you have an iliac vein compression or May-Thurner, it does not mean you don't have your symptoms on the basis of that if you don't have isolated left leg pain. And that's something we've got to get out and teach our colleagues. And then finally, the last thing I'll say scientifically is that at Harvard, they recently published this article, which for me was really interesting, where they took patients with what they call HITCH. It's a giant mouthful, so I'll tell you what it means, but it went over my head at first. It's called hypocapnic cerebral hypoperfusion, which is a big mouthful. It basically just means all the symptoms of dysautonomia without the increased heart rate versus people with the increased heart rate with POTS versus normal controls. And they did tilt table tests on them, and they looked at blood flow to the brain, and they looked at blood return to the heart, and then they looked at what the physiology was there. And what they saw was that there was reduced blood flow to the brain in the POTS and the HITCH patients when they were tilted up. They also saw their carbon dioxide levels were low. So it was physiology like hyperventilation, which we know causes vasoconstriction in the brain and decreases the blood flow to the brain. And so they believe that there's a cycle of central sensitization that's going on in the brain. So there is a component of dysautonomia, but they also saw in those patients that they had an empty right heart. So they had decreased blood flow and blood return to their heart in the upright position. And so their conclusion was that this could be due to increased venous capacitance and venous pooling. And then they concluded that was because of small fiber neuropathy. So I think they got it right up until that very end point, where I think it's because of actual increased venous pooling in the legs from varicose vein disease. You don't even have to see varicose veins to have reflux in the legs, and in the pelvis from varicose vein disease and from obstruction of venous blood return to the heart. So I've been challenged to prove that that's what's going on. And we've designed a study to measure right heart pressures, measure the volume of the inferior vena cava before and after, and do these tilt table studies to look at cerebral blood flow before and after venous stenting, but we haven't done that yet. So we're very early in our understanding and our knowledge about all of this, but I want you to know that I'm open to all the criticism that the data is too new and too early and everything else. And we just started a nonprofit organization to raise money to study this, because the prospective randomized or sham trials cost millions of dollars. So that's where we are with that. Okay, so enough of background. Okay, so I don't have my Jeopardy music. There we go. Okay, so we thought it'd be fun to play a little game of Jeopardy to see what we know and don't know. So you guys are left room because it's from my perspective. Unless you want to be right room, you can decide. But this is left room, this is right room. So I don't have a buzzer. So we're going to go back and forth. Oh, you're going to be the buzzer? You want to be the buzzer for
with the best of them.
Okay, well, the buzzer has to be for whoever hits it first. So you're going to have to stand up here and see who raises their hand first and wants to do a question.
An hour.
Yeah, well, Sally can make the noises. I know she can do it. I've heard her. She can do anything, really. Okay, what do you guys want to start with? Okay, comorbidities for 300.
I can't watch.
Pelvic pain urinary frequency survey is a validated quality of life survey for what bladder condition?
Wait.
Interstitial cystitis.
All right. Oh, no.
Next.
Oh,
What is, this is Jeopardy, people.
What is, oh,
This
by
is
the way,
Jeopardy. What is interstitial cystitis?
we have prizes.
Okay, good.
Yes, but you'll have to come find me because they're hidden under the tape. Actually, they may be back here. All right.
Okay.
I hid them.
Now,
Right.
now, that was the right answer though. So you get like moral support credit, but it's jeopardy. If I have to explain the rules of jeopardy to Americans, we're in trouble. Okay, right room. What is our next one? Pick a category. Okay, compression syndromes for 200. All right. Oh, well, we didn't go through the whole talk. So what do you call the compression cause of intracranial hypertension?
We have a lot of MDs here. Come on.
I don't blame them if they don't know because this stuff is new.
You should go maybe like update us.
It has a bird's name in it. Too late. Okay, now. Good job. What is Eagle
syndrome?
Okay, but because I punished left room for not saying what is, then we have to be fair.
Okay.
But eagles have a very long styloid bone, which is a bone in their neck. And the styloid bone can actually grow really long and compress the jugular vein against the cervical vertebra and cause intracranial hypertension and contribute to brain fog, fatigue, headaches, and all of these things. So the compression syndromes start from the top all the way down, but we didn't get to that one yet. So not fair, but too bad. Okay, you guys wanted to play? All right, so now left side of the room gets to pick.
What are we picking?
Okay. And by the way, these they don't get harder at 500. It was just the order I thought of them. All right, the unrecognized most common cause of low back pain in young patients is.
Well, hey, you didn't raise your hand. She raised her hand. Oh no, go ahead. Go ahead. Now, I wonder if we could debate that because endometriosis is a big cause of low back pain in teens.
But well, I don't know. So I'll give you that may be unrecognized. Yeah. But I think the people in this room who treat endometriosis at least know that it causes back pain.
How many of you had back pain as a teen? Just, like, how many were told it's in your head? Yeah, it's a big one, that uterosacral sacral endo.
Yes.
It's a big one. Oh. Yeah, she got the t-shirt.
Okay. Well, so, I mean, technically it's iliac vein compression, but reflux disease can cause it as well. So pelvic venous disease, right? Honestly, it can't be that hard because it's me asking the question, right? It is. Correct. Good job. All right. What are we doing next? Myths for 500. When treating pelvic venous disease, you should always start from the blank down.
Don't yell it out because our people at home can't hear you.
Okay, here you go.
What is the head down?
Well, yes.
Stop.
What is the top down or head down? So
Top
the reason that I put this in here is that I don't know how many of you have been on a Facebook group and heard that you have to treat venous disease from the top down. No one. Okay, so this falls dead in this room. There's a lot of fear in my patients who have Eagles and nutcracker and MALS and iliac vein compression. And there's even a non-physician patient who's filmed a YouTube video warning people about getting treated for pelvic venous disease without following this top-down philosophy. There is zero truth to that. Zero. Every patient needs to be evaluated for what their individual symptoms are, what their goals of treatment are, and look at each of the disease processes and figure out what's most likely to be contributing with that, and you start with that. So there's no truth to this top-down philosophy. Okay, was right room? Okay. All right, left room. It's time for people to start getting a little aggressive here. Because I was sitting in the left room. You're my team. Okay. What are we doing next?
What are we doing next?
All right. Imaging for 500.
Imaging for 500.
Okay, but we didn't do the talk, so we'll see if you guys get this. The degree of iliac vein compression by intravascular ultrasound needed to be considered for stenting the iliac vein? How narrow does it need to be?
We have a hand up. We have a hand up from my thoracic surgeon in the room. I feel like she's hacking the system.
Guessing 50%.
What is 50%? You can have the t-shirt, but left room's getting the points. This is
Okay.
Jeopardy, people.
Okay. That means left room or the right room, whoever wins goes to lunch first.
Okay, what's our next category? What's left room? Okay, someone said compression syndromes for 500.
Compression syndromes for 500.
Okay, compression of the fourth portion of the duodenum between the aorta and superior mesenteric artery.
What is mouths? SMAS.
Okay, it's yeah.
Oh, was
So,
that it?
Yeah,
Oh, she
what
did
is
get it.
superior mesenteric artery syndrome? But I'm proud of you for knowing both of them.
Okay.
You get the t-shirt, they get the points.
Okay. How about let's do imaging for 200. I'm choosing now because I'm on the mic. Because the people at home, the people.
Oh, okay. Well, we didn't do the whole talk, so you're gonna have to guess. The percent likelihood that iliac vein compression will be diagnosed on CT venogram.
Why is the back of the room not trying? Okay, I'm back to the front. You want to take a stab?
What is 25%?
Okay, that is not correct. So the left side can
Because you're
feel.
in the shirt.
It's a good guess. Well, so here's the context. The majority of doctors order CT venograms to evaluate for iliac vein compression. So is that the right study to be doing or not is the question. And we didn't go through the whole talk. So there you go.
So just explain the answer.
Okay, so the answer is 50% of the time. So in our POTS patients that we did with Dr. Cutchins, when we went back and looked at how often ultrasound, CT versus MRI were accurate, ultrasound was accurate 57% of the time, CT was accurate 50% of the time, and MRI was accurate 87% of the time. And in my hands, MRI is accurate 99% of the time, but the MRIs are frequently misread because radiologists still don't know how to read these exams.
Is it an MR angiogram or MR venogram or just an MRI?
Okay, well, that is an excellent question, right? So I have a special protocol that we have written out for every MRI machine that exists, Toshiba, Philips, GE, all of the different machines. And it allows us to look for adenomyosis in the uterus. It allows us to look at the ovaries. It allows us to look at the lower lumbar spine, the pelvic floor. And then it also allows us to look at the iliac vein, the renal vein, and the direction of blood flow in the gonadal vein. So we have a special protocol. If you just order an MRV, I actually don't think that helps very much. They do this time of flight imaging that's not helpful to me. If you order an MRA, you'll miss the whole thing. So if you wanted to order something, you're probably better off just ordering abdominal and pelvic MRI with and without contrast. I find that the post-contrast images are the most helpful because you can actually see enhancement of the vein wall. And if you follow that up, you can watch the lumen get compressed. So the radiologists frequently read these exams as normal, which is why patients are having trouble getting diagnosed. And so even if you have a normal exam, you would need a specialist to look at that for you. And even then they get it wrong about 50% of the time. So this is a very hard space for patients right now. Okay. Let's just do pelvic myths. Endometriosis surgery is negative for endo as much as what percent of the time?
Can I say like 9 to 10?
Okay,
Wait,
Sally's
wait,
not
wait,
paying attention.
Wait. Is it, but the back didn't get any. Okay, I'm coming. I'm a coming. There's only one of me.
What is 35%?
Okay, close enough. It depends on the data. 35 to 55% of the time.
My excision is in the back. Like, what do you think?
Yeah,
What
let's
say
ask
you?
our incisionist, because this is just what that says, and what that says about venous disease out
Ah,
there is all
what-
wrong.
what?
So let's,
Oh,
Bring it.
that's actually a good point.
Depends on who's doing the scope.
Yeah. You just.
Oh, all right. Will you stand up with me? Come on. I'm so sorry. We disagree because in our experience, that's simply not what we find. I think that that number is artificially high by surgeons who do not know what they're looking for and are not doing complete excision. So, yeah.
no, so what percent of the time,
Sorry.
so what percent of the time do you think that patients don't have endo as the cause of their pelvic pain if you do surgery? Do you think they all do?
Our data is less than 3% have negative pathology.
Less than
Less
what?
than 3%.
Less than 3%.
So
So
over 97% of patients that we do surgery on have pathology proven endometriosis.
So I think that's important. It's an important point, and it's the same point with pelvic venous disease. I see patients from all over the country, even with a venogram performed by an interventional radiologist, who say that they don't have iliac vein compression. But when it's performed correctly with intravascular ultrasound, most of those patients have a fairly severe iliac vein compression. So I would believe that with the endo specialists say that in their hands, most patients do have endo. And I think there are a large number of patients that have both.
And I would just add that we are very good at picking who goes to the operating room. We're not going to take every single person with pelvic pain to the operating room. So when we take them, high likelihood of finding disease.
Yeah, so probably with endo specialists, then it's like less than 3%. And with general GYNs, maybe that's closer to 30%.
One last comment. I'm Andrea Vidali. I would like to say, one last comment is that although one cannot make the assumption that because disease is there, that's the cause of the problem. And I think that endometriosis being the disease. So I think that, yes, maybe you find it, maybe you find a small amount and you have a positive path, but that may not be the answer. And I think that's very important to consider. And so this is very, very important concept because, yeah, you find it, but was that really the problem? And yes, maybe you were good at picking and whatever, but in the end, that may not be the answer.
Well, and so I think that's
we see
important
plenty of
that-
patients like that. So
I think that the good endometriosis excisional physicians and the physicians studying pelvic venous disease need to collaborate more and better. So I work with Olga Muldoon. I don't know how many of you know her, but I love her to death. And she's one of my, I will say that the relationship I have with her as a physician is probably one of the most rewarding relationships I've had in a physician-physician relationship in my whole career. Because if I don't know that it's pelvic vein problems, I don't want to put a stent in a young patient, I send him to Olga. And if Olga says, I don't think it's endo, she'll send him back and I'll stent him. If she says, I think we should do the surgery first, then she does the surgery first. And it's amazing to have that relationship with someone where there's no animosity and there's no ego about who should go first or second. We're trying to find the right thing to do for each patient individually, and we need more of that collaboration across the country.
Hey, so I do want to say we have 900 questions. So
Okay,
I
let's
think we
stop
should
playing
suspend the
Jeopardy.
board.
All right.
People have been asking if you will release your slides. Are you someone who releases your slides? Some doctors don't.
I don't really know. Well, okay.
Like if we get, some doctors don't, so don't worry about it. If you can't, I thought you have a lot on YouTube.
So I'll tell you the 1 minute story about
Yeah.
this. In my world, I'm being heavily criticized by my colleagues about the fact that it's irresponsible to put a permanently implanted device in young patients without the data, right? So I hired a research team. I take it very seriously. We do the quality of life surveys. We're going to move on to do the objective studies. Then we're going to move on to do the prospective randomized trials. So some of this stuff is public and some of it isn't because
Right,
it's not
that's what I thought.
published yet. And I've been recommended not to release everything out there until it's published and available in the data in the literature. And so some of this is published so far. Much of it will be published in the next year. We plan on publishing at least 10 to 12 articles based on the 1,400 patients we've treated so far of all the retrospective reviews and things. But I have lots of filmed.
Right. So
Talk
GFAM
about that.
has one. If is it open to non-members? Not, it's a membership, but Tracy's talk, she'll think about opening it. we'll put it, if she opens it, we'll let all our summit people, we'll send it out to our mailing list. We have a lot of questions.
Okay, well, we don't-
Also, Endo Battery has one too, right? Do you have a podcast with them? Oh, you have to do their podcast. I don't know if Ginger does. Do you have a podcast with? Oh, we're gonna have a lot of podcasts. Okay, there were questions.
okay,
This is my first question because I can find some of this as a PT,
Yeah.
but then I can't find anyone to treat it.
okay. Well, you said we're not allowed to promote our own practice.
No, you
I-
just
I have a license in 50 states because patients can't get access to care. And I do telemedicine visits from patients from all over the world and all over the United States. I have 3 docs now in my practice with 6 NPs. I have a doctor from Chicago who is, yeah, I know, we got to talk about that, who is going to do telemedicine visits, fly out and do all of her cases at my center for 3 to 6 months until she's really comfortable. She knows how to do this correctly. And then we're going to open one in Chicago. And if the literature continues to pan out, my goal is to do that with physicians all over the country and get better access to care.
yeah. So is this like I do these weird hernia compressions? Is this like that where like only one doctor can read it on scans? Or are we starting to get interventional radiologists that no? So and as much as we have our endometriosis pelvic mappers, we're kind of in the same boat with that too.
Yeah, so
So-
there are other, let me say this, out of respect to my colleagues I have excellent colleagues across the country. I stopped doing everything else in my practice. We do 150 procedures, right? This is all I do now. And so we have a concentrated experience. We're learning a ton. My people are very experienced. My nurse practitioners know exactly how to intake people, talk to them, show them things. There is a video that I actually did because we are trying to get more patients through to help with that about this stuff that you guys just saw. There are colleagues of mine across the country who do a good job with this. The problem is it's hard for me to know what their techniques are. And on average, the patency rates of a stent, which means if the stent is open, in the literature are 96 and 98% at 2 years, which to me is unacceptable. That means 96% of stents were open by themselves. And that after an intervention, only 98% are open. That means 2 out of 100 people have a stent that's occluded or blocked. And that's a permanent thing if they don't get to the right person to open it. And that, in my opinion, is largely based on technique. And there is not a standardized technique for stenting yet across the country. And so sadly, I just saw a patient who was had a diagnostic exam done where I actually trained. And the doc said she didn't have pelvic venous disease. Then she went to the university next door and had 4 wrong procedures done, and then came to me and I fixed it and she's doing great. But these are experienced people who are actually principal investigators on some of the trials that are being done. And so it's sadly a space where doctors really want to help patients, but they're afraid to put stents in young patients. And so the data I didn't show you is that the cursory initial data we have would suggest that the iliac vein compression is far more symptomatic than the varicose veins. So if you treat the varicose veins first, you're not going to hurt the patient unless they have a nutcracker. And then you're going to give them flank pain they didn't have before. And then they're going to have their kidney removed or moved to fix that, right? So most of the patients, I believe, should be stented first. And there's a lot of trepidation about stenting young patients because doctors are afraid. I called a friend of mine at University of Virginia and I said, hey, I got a patient who's so sick they can't even sit up. Traveling would be a nightmare. Would you consider this? And he said, well, when only 85% of the stents are open at a year or 2, how can I justify doing that to a young person? And I'm like, yep, don't want you to do it, right? Because we have 99 and 100% patency rates. So in the last 6 years, every stent that we've put in for patients without a blood clot is still open. So it can be done, but the techniques are really variable all over the country. So I don't even know when people are like, do you know someone here? I'm like, I do. And I know they're a good human and I know they're a good doctor, but I don't know if they know how to put a stent in.
Yeah. I think, so hands up, whoever has a question. Okay. We're going to, as I make so first you, then back there, but you should meet Wendy Van Buren, who has an imaging endometriosis and pelvic pain society. And you guys would be a good match to connect. Also, we're connecting with her next year too. Okay, one question.
Hi. One of the first symptoms I had when I started thinking something was wrong with me was that I get numbness in my abdomen and then I lose sensation in my, that's what you could direct. Okay, theoretically speaking, let's say someone gets numbness in their abdomen and then they have to sit on the floor and wait about 10 seconds to start walking. I'm asking you particularly because of what you're speaking about the iliac nerve and they were told by a gastroenterologist that you have acute visceral sensitivity disorder.
Yeah, so I mean, all of these things are potentially related. And the problem is, obviously, GI symptoms come from a million places. Lower extremity neuropathy is super common. We've been working with Jordan Vaughn and Pierre Corey's groups that are long COVID docs with Dr. Maxwell and Dr. Kaufman in California Centers for Complex Disease Patients. And we've stented hundreds of patients now with long COVID. And there's a viral attack on the endothelial lining of the vessel, we think, that's causing this increased venous capacitance and kind of uncovering patients who were maybe previously compensated but no longer. So shortness of breath, brain fog, fatigue, tachycardia, and lower extremity neuropathy is very common in those patients. And when we're stenting them, which we still have to publish that data, we are seeing about the same thing. 80% of them remarkable improvement, 10% of them not much better, 10% of them can continue to just get worse from their long COVID. So yes, I think lower extremity neuropathy is frequently involved. And I just took a gentleman who was the CEO of a $1 billion company, so very motivated, very intelligent guy in his 60s, ran marathons in bed for the last 3 months after a relatively minor blood clot in the leg after COVID with such severe neuropathy he couldn't walk, opened that up, stented him. The neuropathy was in both legs and walked out of the surgery center without a cane, and his walking hasn't been in bed since. So there's definitely neuropathic involvement with this disease process. The problem is it's all multifactorial, and the reality is we don't understand. What we understand about venous disease is even less than we understand about long COVID.
Are those medication-eluting stents, or do you anticoagulate patients?
So they just did the American Venous Forum, the VEINS meeting, and the American Venous Society just did a correlation, just did a look at all of the published data on NIVL lesions, right? That's the non-thrombotic iliac vein lesions that's ever been published. And they came out with a statement paper in August or September of last year about this because they're trying to standardize the way these things are done and make recommendations on what size and length stents we should be putting in and all these things. And their recommendation is that we do not need to use blood thinners at all. The problem is that if you remember that slide with all the stuff on it with POTS in the middle, a lot of our patients have underlying autoimmune issues, activated inflammatory system, mast cell activation, and I think they're at increased risk for clotting. So we put our patients usually on Eliquis, which is a blood thinner, for a month, and then baby aspirin for 2 or 3 months after that. And that's been our regimen for the last 6 years. And we've had about 1% of patients develop some sort of a clotting complication that was able to be managed either with putting them back on blood thinners or removing the blood clot to the point that they're all still open. Well, we're lucky because most of the time right now, since nobody knows about pelvic venous disease, they don't get to me until you guys have fixed the endometriosis. They've had an endometrial ablation. They have a drug-eluting IUD, and like every other possible thing has been exhausted. But it could be an issue if they're having menstrual bleeding. So what we usually do is just hold the blood thinners or half dose them during their cycle, and then put them back on if menstrual bleeding is an issue.
A question. At times when we operate on people, sometimes we're aware of it before, most of the time, because we do, of course, Doppler studies on patients preoperatively, and we see, generically speaking, pelvic congestion, right? Or we see that on the MRI as well sometimes. And we look intraoperatively and we see, for example, often, it's not that rare, massive dilatation of the gonadals. We see that often. We see the congestion. Sometimes though, the patient, you have to catch it before you put the patient in Trendelenburg, because you don't see it, right? And that's one of the things, is that once the patient in Trendelenburg, you lose your chance. So you only have your chance in this first few minutes before you actually put the legs up. But at times I've been tempted, and I've done it a few times, just ligate the gonadal and say, you know what, let me just ligate this gonadal. I work my way all the way up and I ligate it as high as I can. And if I see a lot of actually pelvic congestion in the pelvis, I'll just go after those veins and ligate them.
Well, I think that's a fantastic idea because the Society of Interventional Radiology reviewed over 65 papers and made a position statement that this absolutely should be covered by insurance. So Medicare, Medicaid, TRICARE, and Aetna cover it. Some Blue Cross policies cover it. Rarely Cigna policies cover it, and no United policies cover it. So it's totally ridiculous that patients frequently can't get insurance to cover an embolization procedure. So if you're in there surgically and you see dilated veins, I would tie them off and cut them out if you
And-
can.
Yeah, so you don't see anything, because one thing that I'm advocating actually is that as part of our exam, we should actually put the patients in reverse Trendelenburg before we actually do our laparoscopy. By the way, you heard it from me first, everybody. Doctors.
Wait,
And I agree.
Okay.
But the
right.
only time you could hurt someone with that, right, is, and I see it fairly frequently in these patients that are sicker with like all the stuff, right? They have POTS, they have MCAS, they have EDS. If they have a severe nutcracker
Mhm.
and they're collateralizing their kidney through the ovarian vein, through the uterus and up the other side, then you tie off the gonadal vein, they end up with flank pain. And then the treatment for that is very controversial, but the most widely accepted thing at this point is auto transplant, meaning taking the patient's kidney out and move it.
That seems like a good, simple
Wait.
thing to do.
so
But I do see that, and one of the things. Sorry, Sal, you want to say something? Sorry, I didn't. mean to-
no, keep talking.
No, one of the things
It is
that
your event.
one thing I like to
Yeah,
say
yeah,
for our colleagues, the surgeons, some of these patients have very significant congestion. Their gonadals are loaded, and I want to give credit to Dr. Larish. Where is he? Yeah, because one time we were in one of these cases, and I was like, I can't find the artery. And we actually brought in the device that he uses for, I want to give him credit because credit has to be,
Okay, wait, while they're doing the switch, this is what I want to say. This is it. We're going to answer questions for 10 more minutes. Those of you that want lunch is open. We will return to this room at 1 p.m., but we are going to keep going with the questions. They're going to do this. And then I think Lori might have a comment, and then we have a question over here.
Very quickly. So we have, the vascular surgeons usually use like a big Doppler because you're looking at,
Into the mic.
The vascular surgeons usually use a relatively big Doppler to assess pedal pulses and stuff. We actually have a micro Doppler. It's teeny tiny. The head is less than a millimeter. We pass it in laparoscopically, and you can selectively find what's artery and what's vein and ligate the veins and keep the arteries intact. My one comment is I think actually ligating the gonadal high is problematic. Just from the varicocele data, it makes a lot more sense to ligate the veins distally where they are. But, controversial. I don't know.
I agree with you, except if you're ligating, right? But so all the data for varicose vein disease in the legs showed that ligation of the saphenous vein doesn't fix the problem. It always recurs because there's too much connectivity. So when we embolize the gonadal vein, we go we're supposed to, we don't all, but you're supposed to go all the way down to the varices, coil and embolize or use medicine to get all the varices and then embolize the entire length of the gonadal vein. And it's a very minimally invasive procedure. Patients tolerate it incredibly well, and you really need to treat all the venous disease. So the only problem with just ligating a portion of the gonadal vein is that, you can just shift the symptoms, right? Like, so if they have nutcracker, now that top part of the gonadal veins open, you may shift the symptoms higher if they're having to reroute through the spinal canal again. But I agree, I can usually get retrograde into the residual varicose veins if it's ligated. In most patients, ligating it will probably do the trick, but the iliac vein doesn't usually cause varicose veins. It causes dilated presacral veins. And as long as you don't ligate those, you're fine. If you ligate those in the presence of a severe iliac vein compression, the patient's going to get an extensive DVT.
Okay, go ahead, Teresa.
Okay, so my question is, you mentioned like all those other comorbidities that come with these venous diseases. Say you're an endo patient diagnosed and you have all the symptoms of those other diseases, but they're not diagnosed. Would you say the prognosis would be best like to just skip right to to someone like you, an interventional radiologist, or get the diagnoses first? Like, what's the better outcome for you?
Well, so I mean, before we do anything, I look for everything. So I feel like each individual patient deserves to have everything looked for. and then take what the symptoms are that patient has that are the worst and determine what is the fewest number of procedures we can do on this patient to get them better. So if all of your symptoms are, you can't eat a bite of food without severe upper abdominal pain, somebody needs to make sure you don't have MALS, right? Now, nausea can come from iliac vein compression. We get rid of nausea all the time, right? But severe upper abdominal pain, that's MALS, SMAS, or nutcracker. If your pelvic pain is mild, but all of that is worse, we need to make sure you don't have those things first. Now, where endo fits in with that, I'm not sure, because the reality is almost every single patient who sees me has already had endo surgery and either been resected or found not to have endo, which may not mean they don't have endo. But eventually, when we understand this disease process better and all these other disease processes, we're really going to have to get together as subspecialists and work together to figure out what the algorithm is for who gets what. But the reality is no two people are the same. So that's where some misinformation from patient to patient is out there.
So I'm a pelvic PT in Colorado. I refer to you a lot. Other than where the compression stockings, are there things that we can document on or help fast forward the insurance approval process that would be helpful for you to get that approved for a patient?
No, because I mean, we honestly don't get the MRIs denied very often unless they say they have to have a pelvic ultrasound first. And then we just order a pelvic ultrasound, which doesn't answer any of the questions other than if their uterus and ovaries are normal. And, you know, most of the time they've already had that ruled out. But the pelvic PTs, you guys, the collaboration has been amazing. And, you know, quite frankly, even if we fix the pelvic venous disease, they still need PT to get rid of the muscular spasm and the chronic changes in the pelvic floor as a result of the chronic pain. So I appreciate the collaboration very much.
So my question, I think you partially alluded to in answering her question, was let's say a patient has not had endo excision surgery or an endo evaluation, but is presenting with this constellation of symptoms, sort of who goes first?
Well, that's why I thank God for Dr. Muldoon every day. So now I have an endometriosis excision specialist who I can trust with my life, you know, 2 miles down the road from me. So if I've diagnosed the venous disease and I recognize my limitations of not being as good at determining whether I think it's endo, then I send them to her first. And then we have a conversation and decide who goes first. We're not always right. Many people need both. But I think we have a higher percentage of being right because we collaborate. And so over time, we've got to get that collaboration to be a national collaboration between vascular specialists and endo excision specialists.
My follow-up question was, you mentioned you have an MRI protocol specifically to evaluate this. Is that protocol something that you would be willing to share so that we can order our patients the correct imaging? Dr. Sinervo alluded to, like, what do we order?
Yeah, absolutely. Just email me. Did you guys get my email?
Yeah.
I'll put it up there.
Yeah, no, we have one in the front. Oh, that's on.
Yeah. Just a quick segue to the imaging question, because does positioning affect the result of the imaging? Because obviously MRI, you're going to be, you know, you can't have people standing, right? So
yeah, no, it really doesn't.
Is
For
it
me,
affected in any way by, you know, imaging wise, the position? Have you ever tried to do imaging with a patient standing?
I've never needed to. I don't think so. In theory, if someone has an iliac vein compression as the cause of the problem, it's supposed to be a fixed lesion, right? Like, so when you do an intravascular ultrasound, we don't really see any respiratory variability. The lesion is fixed. So, the other thing is that I don't know if it is, and if it's not, I'll post it on our website. I can post the MRI protocol on the website too. That I'm happy to do.
How hard is it to get with a transabdominal ultrasound to see the lesion with a regular transabdominal ultrasound?
So there are some amazing sonographers across the country who do excellent transabdominal ultrasound. The problem for me is that it takes about 2.5 hours to do an ultrasound of the left renal vein, look at both gonadal veins for reflux, look at both internal iliac veins for reflux, look at the varices and look at the common iliac vein. And depending on the patient's body composition, right? Small patients you can see with ultrasound pretty well. Larger patients, pretty hard to get really good data with that. If you have an experienced center that does this, and there are a few across the country, there's a group in Maryland who's doing tons of this stuff, you know, you can do this with ultrasound. But, you know, one of my friends at Cornell told me he does them all himself. I'm like, I would never see a patient if I tried to do that all myself. It takes an hour and a half to 2 hours. You must not be doing very many of them, right? So for me, the MRI, and I've also seen I think we've diagnosed 5 lymphomas this year. We've diagnosed multiple other problems, a lot of adenomyosis that was unseen on ultrasound and things that we thought were more likely to be causing symptoms. So for me, it's just easier to get the MRI.
In the front.
Right, good afternoon. Kind of two-part question because she wants a little bit of it. If someone in theory was diagnosed as a preteen, started their menstrual cycle with vasovagal syncope.
Yeah, that's almost always iliac vein compression if it's related to venous disease, because most of the gonadal vein and varicose vein problems occur after pregnancies, right? So the more pregnancies you have, the worse it gets. The worse the syncope gets, the worse the leg pain gets, the worse the vaginal pain gets and all that. If you start with symptoms with your first period, Dr. Watson, who's a GYN, who started all this with me 6 or 7 years ago, it's his theory, so I'm not going to take credit for it. And I don't know if there's any reality to it yet. His theory is that that's all iliac vein compression and not endometriosis. You haven't had time to slough your endometrium yet and spread it, but okay. Well, I don't think that that's true. Was my next sentence. I don't think that that's true, but I do think that there's a lot of venous congestion in the uterus in patients with iliac vein compression. And so I think that that's probably maybe or may not be why there's such a high rate of endometriosis in the iliac vein patients. But the standard of care is currently still to rule out endometriosis first.
Oh, at least we get a standard of care where we're ruling out endometriosis first. That never happens. So the reason why that cannot be true is that endometriosis is not endometrium, and it actually has nothing to do with retrograde menstruation. And we're going to go to the next question.
Well,
and then
but isn't it considered hematogenous spread, or that's all bunk too?
no, it's really considered laid down embryologically.
Oh, okay.
You know,
Well,
which I would bet some of these are embryologic.
well, they're all embryologic.
Yeah, yeah, it's a whole, yeah. There's actually a lot of similarities. So ask your question, then we're going to conclude.
Okay, I'm a pelvic PT, and I see a lot of patients with a delayed gastric emptying diagnosis, but they seem to have other symptoms that are not explained, but the physicians like to blame it on that and then send them to PT. So in your experience, do you see a gastroparesis diagnosis and then also find these?
Oh
venous
yeah,
disorders?
very commonly. And the problem is sometimes those gastroparesis diagnoses are real and sometimes they're not, right? So if the gastric emptying is marginal, that's probably not the problem, right? If they have a nuclear medicine study showing that they have severe gastroparesis, that's the one thing we're not great at fixing. But all of the other associated symptoms that aren't specific to emptying the stomach, abdominal pain, all of the other things, I see them all in conjunction, and those things tend to get better. But that's why they do celiac plexus blocks for MALS, because MALS and gastroparesis are the closest linked. So if they block the celiac plexus and the patient goes out and eats a cheeseburger and a pizza that they haven't been able to eat for 3 years, they have MALS.
Very interesting. Okay. First of all, is Dr. Brooke Spencer coming back for part 2 next year? This is like are you gonna same weekend next year? But and more POTS, because that's our most requested thing to discuss.
Well, that's why I skipped forward to the POTS paper. We'll have more data. We're actually going to publish. You guys talk about shaming. I feel like I can say this to this group.
Right.
I try not to say negative things about other physicians, but I did have an older male physician from a very prominent institution on stage say to me last year when I presented POTS data at a meeting, "I'll believe it when you show it to me in men."
Well, that's not good. Also,
so we will be publishing this in men in the next year,
right,
and we can bring that back as well.
So for someone who wore an I don't give a fuck sticker for half the conference, obviously you could say that here. Kind of reminds me when Adam Duke had to do the debate between Chuck Miller and David Redwine. You know, it's the best picture we ever took, the look on his face. So we are so happy to have you here. Are you joining the Tiki Tiki? Or are you going? You have another conference. Oh, so she's Tiki Tikiing for those that want to talk to Dr. Brooke Spencer. And we are returning and starting at 1. And we can't, it's very interesting. Also, okay. Our next gaslighting story, we'll only do 1, and then I'm closing the door, and those people have to go home. No, I'm just kidding. When I asked my female doctor if I could have endo, because of my painful periods. She says it's not possible because she had endo and I would be throwing up during my period, and she actually was wrong. That's a good one. I'm saving all the cards, by the way. All right. How about this one? GI doc told me nothing was wrong. All the tests were normal and that I needed to see a therapist. I said, I already do. And he said, well, then it's your anxiety. Few months later, I had excision and surgery and stage 4 endo and severe SIBO. Okay, last one, and then we'll get started. All right, last one. Oh, I like this person needed extra room and knew to turn the card. Very impressive. Being told over and over by doctors and even certain family members that my daughter was fine, she was acting out, and I was the problem. I hate this momectomy. We already discussed my feelings on that, and I was the problem, that I was convincing her I was sick. Turns out she has celiac, endo, and dysautonomia. It's not in my head. Yes, I think our moms are, for many, a champion, and no momectomies in this room. Now, we're going to start our surgical panel. This is a very important panel because it's notice all female surgeons. So first of all, if you are sitting at the tables and there is an empty chair next to you, raise your hand. And everybody should filter towards the front. Come on. If you are standing and want a seat, you need to find lots of chairs up front. Okay. I want to introduce to you our all-female surgical panel. From Rochester, where it's snowing today, a Endo Summit first timer. Please welcome Dr. Megan Kennedy Burns. A Californian and also a first timer to the Endometriosis Summit. Please welcome Dr. Mallory Stuparich. From Jacksonville, another first timer. Oh my God, I didn't realize this panel. Dr. Akriti Karuba. Not a first timer. From New York and New Jersey, Dr. Lori Liu. From Atlanta, Georgia, a pioneer in surgical nursing, please welcome Wendy Weiner. So Wendy's plane was delayed and she told the pilot, she shook the pilot a little and yelled, I have to get to Sally Sorrell. And I'm not kidding. From California, a veteran of the Endo Summit, please welcome Dr. Mona Orati. And our moderator for the day from Mayo in Arizona, Dr. Megan Wasson.
Oh, can I have that, Sally? So I first just want to thank Sally for giving our fabulous female surgeon panel the opportunity to be with all of you today. This really is a unique opportunity to not only highlight the amazing surgical skill set that's sitting in front of you, because we saw a lot of that yesterday, but really give an opportunity to share a little bit more about what makes us tick and why we do what we do. So understanding a little bit more of the personal aspects behind being a female surgeon caring for those with endometriosis. And so I do want this to be a very interactive session. I do welcome a lot of questions. So that's why I have a handheld, me running around. But to get us started, I'm just going to have